Thank you very much for this kind introduction to FIGO. I'd just like to thank FIGO and the FIGO headquarters, FIGO trustees, and my dear friend Professor Pai for the invitation to speak here today. I've been asked to talk to you about luteal support in intrauterine insemination and ART technologies. This is where I work at University College Hospital, Galway, and thank you for the kind introduction. Okay, so what I'm going to talk to you about is we'll start off with the physiology of the luteal phase and the role of progesterone, and then we'll talk about progesterone in intrauterine inseminations. We'll then go on to talk about progesterone in ART, which is IVF, ICSI, and frozen cycles. I'll briefly touch upon the endometrial receptivity testing because that involves the luteal phase. And then we'll try and figure out what the breast progesterone is, and we'll try and conclude. So, before ovulation, the granulosa cells from the dominant follicle begin their transformation by enlarging and becoming vacuolated. These vacuoles take on the yellow pigment lutein, which when we do a laparoscopy, we can see the yellow body, the corpus luteum, and it gets highly vascularized, something that we know very well on the occasion where we have a lady who bleeds intraperitoneally from a vascular corpus luteum, and that releases the progesterone. Now, there are multiple experimental designs correlating tropic LH secretion to the progesterone production from the corpus luteum. And one old classical experiment was when they obliterated the basal hypothalamus of the rhesus monkeys, there was an absence of GnRH analogs, and these monkeys were then given exogenous GnRH in a pulse-style form, and as a result, the LH and progesterone rose. But when the external GnRH analog was stopped, the LH and progesterone disappeared. And we also know as the pregnancy advances, the corpus luteum supports this pregnancy. And all studies have shown that when the corpus luteum was surgically removed under 7 weeks, the pregnancies failed. When the corpus luteum was surgically removed between 7 and 9 weeks, a lot of the pregnancies failed, but after 9 weeks, even if the corpus luteum was excised, the pregnancy continued because the reliance on the corpus luteum was gone and the placenta had taken over the production of progesterone. We also know that even if you remove the corpus luteum surgically and externally supplemented with progesterone, the pregnancy would continue. So let's look at progesterone in spontaneous conception. Now, very often we give patients progesterone because we feel there is a luteal phase defect in the corpus luteum. But even though progesterone supplementation is very often given, there is no published evidence that shows an improvement in pregnancy outcomes when pregnancies are conceived naturally. So in summary, there is no benefit from giving progesterone in natural conception in the luteal phase. But when we look at progesterone in intrauterine insemination, this paper by Kathleen Green looks at 11 trials with almost 3,000 patients undergoing 4,000 cycles, and they showed that in patients really receiving gonadotropins, which is FSH injections for ovulation induction, alongside intrauterine insemination, the clinical pregnancy rate and the live birth rate was measured when progesterone was supplemented in the luteal phase. And these findings persisted into live birth rates, but there was no benefit when progesterone was given when clomiphene was used or when clomiphene was used with gonadotropins. And this is backed up by another RCT by Casaramona that shows that if you compare luteal phase support in ovulation stimulation cycles with gonadotropins, i.e. follicle stimulating hormone, with intrauterine insemination, it results in a higher clinical pregnancy rate and a higher live birth rate, but this is not seen with clomiphene citrate. Now, moving on to IVF and ICSI treatments. It is clear that the luteal phase following controlled ovarian hyperstimulation and oocyte aspiration is dysfunctional, a fact that's been known for a long time. And currently, the theory is that luteal phase dysfunction after IVF is a result of the supraphysiological steroid levels secreted by all those various corpus luteum in the early phase of the IVF cycle, and it causes direct inhibition of LH secretion through negative feedback. Now, in a frozen cycle where we medicate with HRT, such as estrogen in the first half and then the addition of progesterone, the estrogen acts like the pill, it suppresses ovulation, there is no corpus luteum, so then progesterone is the obvious choice for the luteal phase, because there is no corpus luteum. So what progesterone is ideal? So IM progesterone is one option, and the dose has ranged from 25 microgram to 100, with the average being about 50. It is more popular in North America. It does have rapid absorption. You get high plasma levels in about 2 hours. But the downside is you have redness, pain, infection, and abscesses. And we all know as clinicians, those gluteal abscesses are very slow to heal. The other option is vaginal or rectal micronized progesterone. Avoid oral because it doesn't avoid the first pass metabolism. And Devereux has shown that about 300 to 600 milligrams of progesterone will give you adequate serum levels within 3 to 8 hours of utilization and is equivalent to about 100 milligrams of IM progesterone on histopathological studies. If we look at oral dydrogesterone versus micronized vaginal progesterone, Baidya Chakravarti looked at oral dydrogesterone versus micronized progesterone and found a benefit in using oral dydrogesterone. And this was also confirmed by Amit Patki from Mumbai a few years ago. When we look at Mustafa Metwali's Cochrane review, he says for the outcome of clinical pregnancy, subgroup analysis of micronized progesterone versus synthetic progesterone showed a benefit for synthetic progesterone. And when they compared the subgroup analysis of multiple pregnancies, IM progesterone versus oral synthetic progesterone showed a benefit for synthetic oral progesterone. Moving on to vaginal progesterone versus the newer subcut progesterone, which is known on the market as Prolutex, the non-inferiority study done by Lockwood showed that subcuticular progesterone is just as good as or not inferior to vaginal progesterone, and this was confirmed by Valerie Baker in her RCT. So, in summary, vaginal progesterone or subcut progesterone is just as good as vaginal progesterone. What happens when we compare vaginal micronized progesterone to intramuscular progesterone? So if we look at, say, frozen cycles with donor eggs, so 2 small prospective randomized trials from Toner et al. Showed no difference in ongoing pregnancy rates when comparing intramuscular progesterone to vaginal progesterone in donor oocytes. However, 2 retrospective studies in women undergoing frozen transfer suggested a decreased live birth rate with vaginal compared to intramuscular. So the jury is still out. What happens when patients get pregnant and they're on the vaginal progesterone or the intramuscular progesterone? Is there any benefit in going past a positive pregnancy test in an IVF cycle? Now, some people give it up to 12 weeks, others up to 8 weeks, but Ziliu has shown that there is absolutely no benefit in giving progesterone past a positive HCG in patients who have had a fresh cycle. Yet, when Eddie Weisbuch sent out a questionnaire, 72% of the clinics continue to use it till 8 weeks. I do briefly want to talk to you about the role of gonadotropin-releasing hormone agonists for luteal support. And this is something new that we've brought into our practice. And there are studies showing that one single injection on day 5 or 6 of after egg collection may actually improve the success rate. So this meta-analysis with over 3,500 cycles showed that there was a benefit giving one dose of a GnRH agonist, and it improves the clinical pregnancy rate, ongoing pregnancy rate, implantation rate, does not increase the ovarian hyperstimulation rate, and reduces the rate of miscarriage. But one might remember that at some stage we were given 3 doses of HCG. So how does giving one dose of a GnRH agonist compare with 3 HCGs? And this Turkish study has shown that one dose of luteal phase GnRH analog, whether that's 0.1 milligram of triptorelin or 0.5 milligrams of buserelin, is as good as 3 HCG doses. But what's the advantage? You don't get the ovarian hyperstimulation that comes with the HCG doses. So, in summary, when the data was pooled looking at GnRH agonist versus no GnRH agonist, there is a benefit in clinical pregnancy rate, but no increased risk of OHSS. I'm going to very briefly talk to you about endometrial receptivity. A few years ago, this was touted to be, the new thing on the block, where one could look at the progesterone window. But this study shows that 8 studies with over 800 patients that had an ERA versus 1,900 that didn't showed no difference in implantation, biochemical, clinical pregnancy, and miscarriage rates. So endometrial receptivity is probably not going to benefit your patients. So in conclusion, there's no role for progesterone in spontaneous conception in the luteal phase, though it will benefit you if you do ovulation induction with gonadotropins. You can use oral dydrogesterone for patients who can't tolerate vaginal or intramuscular preparations, and vaginal, intramuscular, and subcutaneous progesterone probably have the same efficacy, though intramuscular may have a higher side effect profile, and the ERA test may not be the answer to the implantation problems. Once again, thank you for the invitation, and much love to your families from mine in Galway.
That was a really wonderful talk by Nikhil, Professor Nikhil Purandare, and now I think we will now go for the Q&A session. So you please, all the participants, please post your questions in the Q&A session. And I think the first question is in a little bit of a, the language is different. So can anyone help me at the headquarters? Hello. Okay, I'll take the second question that is directed to Dr. Rohana. Does PRP has an effect on endometrial receptivity? Dr. Rohana is there?
No, he's not there.
And okay, he is not there. So, Dr. Nandita, one question I would like to ask you about the, which is the better, in endometriosis, would you like to operate or do the IVF? We have thrown a light, but this has always been a controversy kind of.
Yeah, I think I got a question also which I answered. Actually, they were asking me whether to do primary surgery or primary ART. So today the decision is out saying that the primary ART is always better. Surgery should be avoided in infertile patients if possible. Surgery is only done if there is pain associated with endometriosis, or if accessibility of the follicles is a problem when you're doing OPU and the endometrioma is too big. So as far as possible, prevent primary surgery, go for IVF if possible.
Okay, well, this was one question I would like to direct to all the panelists. While doing the endometriosis, I've had few in my career of 35 years, few infections, abscesses. So we, as a rule, give IV antibiotics. So we have started using, because normally for pickup we never used to use any vaginal prep as such, betadine and all, because we always were worried about iodine damaging the embryo. So what about all of you? Do you use betadine or any vaginal prep before retrieval, or as a rule, or in few exceptions, or if there's any adnexal pathology, would you use that for retrieval? Any one of you can take that.
Yes. If we have endometrioma, so we prefer to directly proceed to IVF, and then it's very important to see before we did the stimulation. Very important to see how big the cyst and then how the cyst will interfere the growing of the follicles and also any disturbances for the oocyte retrieval is very important before we do the ovarian stimulation. And then during the egg retrieval, we should avoid the endometrioma to puncture or to penetrate endometrioma. We should avoid it because it is a high risk to make infection. So that's why we should do the egg retrieval very carefully and then very precisely. And then it's very important, sometimes we left the follicles beyond the cyst to avoid the penetrate the endometrioma. Thank you.
Okay. So there's a question for Rohana, which you can, any one of you can take that question. There's one or two questions by Hadiza and even by Joram on whether HIFU can be used for fibroid. So this is a new kid on the block, and a lot of them are talking about HIFU. So what is your take on that? All of you, even Marcus has joined us now. So welcome, Marcus. It was a wonderful talk. And so, what is your take on HIFU? All of you, what do you think that is HIFU a good technique, and should we use it? Will it improve the results?
Well, thank you for the invitation, Rishi, and a great meeting. And I'm sorry I won't be able to answer about HIFU because I got no experience, so I leave the other participants to respond that.
Is there any Nikhil or Nandita? I think we also don't have much experience on HIFU, but yes, I mean, because the endoscopic surgery is so good. So of course, it's a non-invasive technique, and some amount of one of my colleague, Dr. Ishma, has been using it in a practice, and it can reduce the size. So we can try to use it. There have been studies showing a good outcome following HIFU, but the problem is the technology is very costly at present, and that's the biggest hurdle in implementing that technology in our field. So there's another question again. It's because gynecologists are all technique related. So this question was on using a tunicate during abdominal open myomectomy. Does it significantly reduce the ovarian reserve? That's a really tricky question. I never thought of it. And this is from Oladimechi Makinde. So any one of you would like to answer that? Suppose you do an open myomectomy and you use a tourniquet, will it affect the ovarian reserve?
I think it's very, sorry.
No, fine. Go ahead, Nandita.
It's very temporary, so I doubt that much time would affect the ovarian reserve. And there is collateral circulation also. So the tunicate is only blocking the uterine source of the vasculature. So I don't think so personally for that particular short period of operating time.
Nikhil, what is your thought?
I agree wholeheartedly. I mean, most of the time we put the tourniquet through a small hole in the broad ligament, or we might put it around the low end of the uterus. I'll give you a simple example. If it devascularized the uterus that much, we'd have no bleeding when we remove the fibroid. And you'll realize that there's still bleeding when you take out the fibroid. So there's still vasculature. It doesn't damage the ovaries, and you can continue to use it.
Okay, great. So there's a question for Budi. This is on cinnamon. So it's a really exciting, suddenly this new molecule of cinnamon. So Budi, what is your take? How much cinnamon? The question is, how much cinnamon do patients take, and how do you administer the cinnamon? There's a question from Iruma, and there's an anonymous attendee who has asked the question.
Yes. Thank you so much for the questions. Fortunately, in our country, we have succeeded to make a bioactive fraction of cinnamon, and then this is commercially available. So in the as a tablet, and then so that's why the patients can take it, the bioactive fraction of cinnamon, which is there are two active pharmaceutical ingredient inside, and then it was proven increasing GLUT4 for the transported glucose into the cells. So the patient take it the tablet orally. The dosage is about 200 milligrams daily. So twice they take a tablet twice the tablet daily. And then it is running very well. I think we have published randomized double-blind randomized control trial comparing bioactive fraction of cinnamon with metformin with a good result, with a less side effect, and then with the same side for improving the metabolic performance and also reproductive performance, and fewer side effect comparing to the metformin. Thank you.
Okay, and so I think there was this one question for Marcus from Yukti Bharadwaj. How helpful is mild stimulation in poor responders?
Well, it's been a long discussion about this in the literature, and some people favor mild stimulation because of if patients won't get a high stimulation anyway, so why don't you stimulate mildly? But the other point opposite to that is that we all know that we need a lot of eggs to get a healthy embryo. So there's no use in having a mild stimulation if you can get 3 or 4 eggs instead of one, or if you can get 8 eggs in a double stimulation instead of 2 or 3, you'll be much better done because you'll get a much better chances of having a euploid blastocyst. And we know that what we need to get pregnant are healthy embryos, and you need a lot of eggs for that.
So, on the following up on this, Marcus, so, the Sankara's paper was there about the GnRH agonist, but with all the double and triple stimulation coming, it's all antagonist based, isn't it? So,
Exactly.
I mean, I just wanted to know what exactly is a triple stimulation because you have done a lot of
Well,
it. So,
it's doing 3 in a row. I just was having a chat with people from Filippo Valdi's group, and they do it also. It's obviously burdensome for the patient, and it's not every patient that will accept to do it. But especially we have done it with patients that do PGTA plus PGTM because of a monogenic condition. So you need in those cases, you have a 38-year-old patient that has their own aneuploidies, and on top of that, you have to select an embryo with a non-mutation that you have to select. So in those cases, we need more and more eggs. But the bottom line is that in ovarian stimulation, you can do 2 or 3 separate cycles, and you won't get the same result as if you do it all in a row because patients get frustrated, and the dropout rate from a failed cycle is more than 40 and 50%. So the way to retain the patient in stimulation is the only objective of the dual multiple oocyte retrieval. So it's just a strategy.
I agree, because that's what I forget the Italian author had shown that if you do back to back, the dropout rate is because people tend to not do the cycles otherwise, and they just let go in the middle. Even though they are insurance covered, they have the money, but still they would go for a dropout. So the other question has been asked by Joram is that about ovarian transplant for poor ovarian reserve. So response, sorry, poor, but what would that be? I mean, you can any one of you can answer that. But ovarian transplant, anyone has got any experience on that? Okay, let's go. Nikhil, there's a question for you. Is which progesterone in intramuscular formulation is helpful? So, I was always under the impression that the American groups are all the time, they feel that they swear by the intramuscular progesterone. Of course, in our groups, we do alternate. So we give vaginal, and every third day we give intramuscular progesterone. And we have started also doing progesterone levels on day 3 after the starting of the progesterone and trying to individualize therapy. So in your unit, are you doing that? And what is your take? Is it that IM is not the best? Because I felt that IM was the best. But because my patient can't be compliant, I have not, persisted with pure intramuscular. What is your take on it?
I think the challenge it's about patient compliance, and when there's no evidence to suggest that one is better than the other, I suppose the challenge is that we tend to start with vaginal progesterone, and patients who have multiple failures are often seeking for other options. And I get the standard question I get is, do I need more progesterone? Do I need more progesterone? Can I have cycles just 3 times a day? And I suppose it's important for us to continue to practice evidence-based medicine. So what I do is, if patients with good quality embryos don't get pregnant and they're young on one type of progesterone, sometimes it's beneficial to change so that the patient feels that there is a change. Whether or not that is clinically significant, it's hard to know because we don't know that the euploidy of the embryo that's being transplanted back unless you have the MPGT tested, and even then you're not certain of its exact genetic potential. We tend to start with vaginal progesterone, and then we tend to migrate to intramuscular if the patient tolerates it. But very often, if the patient doesn't get pregnant, they might migrate back to vaginal or subcut progesterone, and it really depends on tolerance. I recently had a patient with a gluteal abscess, and it only healed by the time I was doing her cesarean section. So these complications can be slow to heal, but if they have good compliance, it's not a bad option because you get consistent serum levels of progesterone.
Okay, great. So, but I know what also wanted to ask you. I think they are saying that is it that we are over? We cannot ask any questions.
I think so.
Okay. So I need to sum up. I think there are a lot of questions. There's one last question I'll take before I sum up. Dr. Suesha has asked, Khanija has asked the question: how's your experience using recombinant FSH and LH combination pen in poor ovarian reserve? So one of you can take that question. Is it good in the poor ovarian reserve patient to have a recombinant LH and FSH? What are you using, all of you, in your practice?
Okay. We do use the recombinant LH and recombinant FSH in our practice. And I mean, sometimes my girls were saying they were not happy with it, but recently again we have started getting better results. So we've not done any comparative study, but yes, we do use the combination. Yeah.
Anyone else before I close it?
Marcus wanted to answer it.
Yes, we also do the combination of recombinants FSH and LH, because most of our patients are around 39 or 39.1. That's the first cycle of IVF. So we usually do both hormones.
Okay, great. So I think I will
look the Poseidon criteria. Fine. If you look the
Puri?
Poseidon criteria,
Yeah.
Poseidon criteria 2 and 3, I think this is a part of the patient that will have a benefit effect if we add the LH supplementation, because there is a polymorphism in beta LH polymorphism. Thank you.
Right. I think so. Basically, in poor responder, it's better to start the combination in whether, HMG, if we want a highly pure HMG or a recombinant FSH combination right from day 2 of the stimulation cycle. So I will summarize this wonderful. You can go on and on, but time is always the problem for all of us. And we have had 5 wonderful speakers, and Dr. Nandita touched upon the endometriosis, and the message that she gave is that in the early phase, that is grade 1 and 2, better to, of course, do an EFI, endometriosis fertility index, to classify the patients, take the approach, and then in the early phases 1 and 2, maybe do a laparoscopic surgery very effectively so that you treat the disease. And then in the latter phases, if the endometrium is less than 3 centimeters, it's better to go for straight away for IVF, if at all you have to do IVF. And only if there is a pain, or there is a like a large endometrium coming the way of the oocyte retrieval, it would be better to first go in, decompress it, but you must be very careful in decompressing. See that your ovarian reserve is not harmed. It's better to do partial cystectomy, and if you have the access, you can use a laser to cauterize the base so that you conserve the ovarian tissue kind of thing. So overall, and she said that there's no difference in whether you do IVF or ICSI, but in my group, we like to dissect the eggs and do ICSI, especially because there's a contamination with the endometriosis sometimes in the follicular fluid, and the clinical pregnancy rate outcomes are similar. So she gave us a nice insight on endometriosis, and then it was followed by a wonderful talk by Rohana Hatatuva, who talked about uterus. Uterus is a very important player in infertility, and especially if there are pathologies like septum or fibroids or adenomyosis or thin endometrium adhesions, all these polyps can all contribute to this problem. And he had shown that if you do an endometrial transfer, and if the transfer is more than and go on increasing till 10. So between 7 and 10 millimeters would be an ideal phase. And of course, he also mentioned that polyp can be removed, and he talked about some kind of stem cell therapy for thin endometrium, and also talked about interstitial fibroid. So fibroid is a controversy. He said that even if the fibroid is intramural and not distorting the cavity, if it is more than 5 centimeters, you should remove it. Personally, in my practice, our cutoff is 3 centimeters, or nowadays, prior to IVF, we tell them that you can do one cycle, even though fibroid is there. If that fails, then in the subsequent cycle, you remove the fibroid before you go for embryo transfer. The third talk was given by Budi Viveko, and he wonderfully talked about the PCOS, and he has got a huge amount of research. And one of the things that stood out in his talk is the amount of research he has done. And the AMH is a very good correlator. Anything more than 3.2 to 3.5 nanograms per ml would be a good biochemical diagnosis of a PCOS condition. And he talked about hyperandrogenism and the correlation of AMH with hyperinsulinism. And of course, he talked about the 4 phenotypes, and that the phenotype 1 had the highest level of hyperandrogenism. And he emphasized on the cinnamon, which is a new kid on the block, kind of, and we can use it very effectively in trying to treat the PCOS. The fourth talk was by Marcus Horton on one of the biggest challenges which we face, and that is on the problem of poor ovarian reserve. And he wonderfully talked about various stimulation protocols, the duo-stim, the triple stim protocol, and that it's a way of strategy. Maybe it will not improve the pregnancy. Overall pregnancy rates are comparable whether you do a standard stimulation protocol. But what happens is that if you do these multiple stimulation cycles in a short span of time, then patient doesn't have enough time to think of dropping out of the cycle. And that's where the pregnancy is. That's where the number of times the patient goes in for the stimulation, that gives the patient the pregnancy. So it was a wonderful talk on this. And he also gave us some analysis on rapamycin, which may be a new drug, a new molecule, which can maybe conserve the ovarian reserve. So these are exciting times. And then talked about the PRP. There is no difference in outcome, but we, in our group, we also do PRP, and sometimes we are also now doing stem cell combination and putting it back into the ovary. And then finally, the whole seminar was summed up by Nikhil Purandare with his wonderful talk on luteal support for IUI and ART, and he elaborated on the different routes of progesterone that are there available: oral, vaginal, intramuscular, and subcutaneous. And there's no definitive consensus, though the overall consensus has been that intramuscular gives the best outcome. But the problem is with compliance. To give an intramuscular injection for 14 days after the transfer is not a joke. And maybe the evolution of newer oral progesterones and like dydrogesterone and the new subcutaneous progesterone may be a replacement. In my practice, of course, I use a combination of a combination of vaginal with a subcutaneous or intramuscular every 3rd or 4th day of the luteal phase. So he also threw a light on GnRH agonist injection to be given on the 5th or 6th day after the oocyte retrieval. And he also talked about the ERA test, and that it's not really the outcomes are not statistically significant. So overall, I hope that I just wanted to pick up these 5 important aspects. I didn't touch on the laboratory aspect of embryology and culture because that's a totally different ball game. But I hope that we have given you a wonderful insight. And if these seminar will be available to all of you. This webinar will shortly become available on demand on the FIGO Knowledge Hub. The link to the short webinar course is being posted in the chat and will be emailed to you shortly. You can use this link to obtain a certificate of completion for this webinar by simply completing a short quiz and survey. Recordings will be added to this link 1 week following the webinar. And last but not the least, before I sign off, we are all waiting for you to come to Cape Town for our fantastic the 25th FIGO World Conference taking place in Cape Town, South Africa in October 2025. And I would like to tell you that the registration will be open in January of this coming year. The website is being posted in the chat and which will provide you with more details about the scientific program. Thank you very much, and we look forward to seeing you at